dyspneic patient, illegal immigrant from Pakistan. In my institution, there are young people with no papers who have the possibility to be cured. And he was very, very dyspneic, and he was referred for CTA because anytime the patients are dyspneic, I don't know if it's the same in Israel, but in France, our colleagues believe there's a P. So, dyspneic, we don't think, we don't lose time, and we ask for CTA. And this is the CT images. Can you see something abnormal? No?
Le cœur et qualité droite. Il a pas dans le cœur.
Okay.
Il a un gros
So,
cœur.
I selected these 3 images because I think that they represent the whole pathology. So, what can you see here on this image? What's abnormal here? Are the interns flipping yet? No? And now, does the microphone work? Can you hear me? Yes. Okay. So the interns, the residents, what do you think? Something is abnormal here. What is abnormal? There's a right. You're right. There's this tubular connection between the descending aorta and the pulmonary artery. How is it called? It's a patent ductus arteriosus. Okay, it's abnormal. And okay. Okay. What is abnormal here? A huge dilatation of the pulmonary trunk. Okay, so the patient has pulmonary hypertension, right? Okay. And what is abnormal on the 3rd image here?
Okay.
Is it normal to have such a communication between the 2 ventricles? No. There's first something which is related to the pulmonary hypertension. It's the thickened right ventricular wall. It is as thick as the left myocardium. It's very abnormal. And the second abnormality is the ventricular septal defect. So the patient did not have PD, but he had an undiagnosed and uncorrected congenital heart abnormality, ventricular septal defect, and he was referred in emergency to our unit because he was suspected of having PD. So you need to be able to recognize such abnormalities even though you're not specialized in pediatrics or in heart diseases. And this is what we call the Eisenmenger syndrome. It's the most severe form of pulmonary arterial hypertension. It arises on the basis of congenital heart disease with a systemic to pulmonary shunt. Adult patients with the Eisenmenger syndrome suffer from a complex multisystemic disorder, including bleeding complications, especially massive hemolysis, paradoxical embolism because of the communication between the systemic and pulmonary circulation. You can understand that clots from the lower limbs eventually can reach the systemic circulation and cause paradoxical embolism. And they also suffer from heart failure, reduced quality of life, and premature death. And at this stage, the only solution is to perform heart transplantation, which is not very easy to plan in a patient who is an immigrant. And this first clinical description was performed by a Venous physician, Dr. Eisenmenger, and this syndrome was later refined as pulmonary hypertension due to a high pulmonary vascular resistance with reverse or bidirectional shunt at aortopulmonary, ventricular, or atrial level. In our patient, it was at the ventricular level, and I think that the patent of the arteriosus was only the consequence of the septal defect, but was not the primary abnormality. And initially, the patient had a left to right shunt because the pressure is higher in the left heart cavities, but with the time, the vascular resistance increases in the pulmonary circulation, and then finally, due to the development of the pulmonary hypertension, they reverse their shunt, and so they have cyanosis. Okay? And if you want to know more about the Eisenmenger syndrome, you can read this paper. So this is my case number 5 that we just saw, so you know everything about it now. And it is so obvious that sometimes, just to show you, I played with the color yesterday instead of going a bit lost to the response. And it's so obvious that sometimes it is missed, especially because the patients are asymptomatic. But it needs to be detected in case of thoracic surgery. Imaging the patient needs to have left lung pneumonectomy. It is very important to mention she has this anomalous venous return. So case number 6 concerns a 72-year-old man with COPD. And he has no special symptoms except symptoms referred to his COPD status. And this is the CT scan. And I want you to depict at least 3 different abnormalities, okay? So pay attention. Again. Okay, I will leave this image for you. So, I need you to find 3 different abnormalities. So, what do you suggest?
Left side SVC.
What?
Left side SVC.
Correct. There is a left SVC here. It's perfect. You can see that this vein is not an anomalous pulmonary venous return. You can see that there is no left brachiocephalic vein, and this vein finally reaches the right atrium by joining the coronary sinus here. Okay, so there is no shunting. It's a systemic vein joining the right atrium, so no shunting. This is the first abnormality, and the 2 other abnormalities are
Cancer,
what?
un nodule,
There's a pulmonary nodule here is speculated. It is more than 1 centimeter. What do you think it is?
Cancer.
Hmm?
Cancer.
Yes, it is a lung cancer. And I biopsied this nodule, and it was squamous cell carcinoma. So this is our abnormality number 2. And last abnormality,
Crazy piping.
pulmonary emphysema, and also the bronchial wall thickening, which are related to the COPD status. Okay? So, what do you need to know about persistent left superior vena cava? It's the most common congenital venous anomaly of the thoracic systemic venous return, occurring in 0.3 to 0.5% of individuals, and it's more common in patients with other documented congenital heart abnormalities. And in this case, the left brachiocephalic vein is missing. Okay? So, I showed you several examples of venous abnormalities that you need to distinguish. So, pulmonary partial anomalous pulmonary venous return is responsible for left to right shunt. Usually it is asymptomatic because it is oxygenated blood joining the systemic venous circulation, and it does not create symptoms, whereas right to left shunting is responsible of systemic desaturation and creating symptoms. And on the right side, this is the connection of the pulmonary vein to the SVC. And in the left lung, it is the connection of the pulmonary vein, usually the venous drainage of the upper lobe to the brachiocephalic vein, as shown here. You can see here the pulmonary vein, the venous return of the left upper lobe, crossing medially to the pulmonary artery, and joining here the left brachiocephalic vein. So this creates left to right shunting, and whereas the left SVC does not create any shunt, and usually the left SVC joins the right atrium via the coronary sinus, or another option, it can go to the other side and join the right SVC. And so, having this in mind, you know all you need about the pulmonary, the venous thoracic anomalies, and they are not so infrequent. So I suggest that each city you're reading, you need to check that the pulmonary veins join the left atrium systematically. And this is my last case. In an asymptomatic young woman. Okay, again. So, there's something abnormal. I can say again. Okay. Case 7. Slowly. I think that you believe this is not totally normal. So maybe on the adjacent images, try to find where this vessel is connected. To the celiac trunk. Perfect. Dr. Guilherme is a specialist of the celiac trunk. So it is usual that a vessel in the lung is connected to the aorta or to branches of the aorta.
Séquestration.
No, it is. And indeed, it is a pulmonary sequestration. And the another abnormal finding here is the lung parenchyma, which is not normal in the left lower lobe. You can see here hypoattenuation, and this is partly due to emphysema and partly due to air trapping, because you will notice that the bronchi are missing. Here you can identify the posterobasal bronchus, B10, and here you can't. And the last abnormality is this, and this is not really abnormal. This is the venous drainage, and in this case, it was connected to the left atrium as it usually does. So the venous drainage in this case was connected to the pulmonary vein and to the left atrium, and not to a systemic vein. And this is the main distinction between intralobar or extralobar pulmonary sequestration. And so if you have so bronchopulmonary sequestration is an uncommon pulmonary disorder characterized by an area of non-functioning abnormal lung. In this case, you had the air trapping in this area, and it receives its blood supply from a systemic artery. In this case, it was a systemic artery arising from the celiac trunk, not directly from the aorta, and characteristically, it has no connection with the sacroiliac tree. And in the intralobar pulmonary sequestration, the abnormal lung tissue is located within the visceral flora, whereas in the extralobar form, it has its own visceral flora. And the venous drainage in the intralobar type is connected to the pulmonary veins and then to the left atrium, whereas in the extralobar type, which is much more uncommon, it is connected to the system. And I think I finished. Thank you for your attention.